Fly me to the moon. Fly me to the moon. I'm ready for karaoke.
Those are do not approve by nay. Motion pass. Okay. Back to my agenda. All right. Dr. Duncan, you're up. Good morning.
Good morning, Chairperson, Ms. Debose. I'd like to first of all give an update on a couple of searches that we have going on. The first one is for the SVP of the foundation. Hearts has closed in on a number of candidates that will be presented this afternoon.
Pull your mic a little bit closer to you. So.
Good morning. I'd like to first update the committee on two positions that have been out for search. The first one is for the SVP of the foundation. Hearts has closed in on a number of great candidates that will be presented today to Ms. Debose and Ms. Arizola. Along with myself, we will narrow that list down and decide who will come in for an interview before the staff and before board members. So I did want to give an update. So we should be closing in on that fairly soon. The second and most important is the SVP of HR. I am looking forward to closing in on that. We did, just to remind the board, expand that search. In 2 weeks, Hearts will come back with that expanded search. Again, we will narrow that down and determine who will come in to be interviewed. I anticipate that that search will probably be completed. It will have a warm body here by the end of first quarter next year. And I have reached out to B.E. Smith to provide interim coverage until that time. I feel that that's important as I transition into my new role to offload some of the HR duties. We have a really good candidate. Her name is Lorenza Key Bridges, who I interviewed. I interviewed several candidates. She comes highly experienced. She has sat in as the chief HR officer at several organizations, including Carolina Health and Tenet. And she interviewed well. I think she will be a good fit. So she will serve as interim until we name our permanent. So I did want to update the board on that. Any questions? Okay.
Is there any significance to being a CHRO versus SVP HR?
You know, it's interesting that people do like that CHRO title.
Okay.
It tends to attract when we're going out and doing a search. We traditionally have used the VP, SVP, EVP title, and we'll be consistent with that as we bring that person on.
Thank you.
I do want to, Chuck had asked me to give an update at the big board, but I think as part of the HR update, Dr. Weber, I'm sorry, had asked that I give an update to the large board meeting. But I do feel that the activities that we have had with our staff have been really great to have during times of COVID when we've continued to mask and social distance. So we had our annual turkey toss. Just to remind you, we had moved that from close contact to a drive-through, and we have truly mastered that operationally. We gave our staff came to pick up over 2,600 turkeys, over 2,600 hams were given, and 350 fruit baskets. There were about 700 items left over following the turkey toss, and those were donated to the Tarrant Area Food Bank. And so it was a great success for our team, and we'll continue to look to have that in future years. The other event that we had last weekend was what was called the Celebration of Lights, and I want to thank Chairperson Ms. Debose for attending that event. It was our first time having this event. We were able to do it out in the green space. We had over 1,300 team members and family members attended. We did open it up to family members. And we lit the Christmas tree, and it was really nice. And so I do want to inform the board about that. So those are the activities. Before we get started on the remainder of the agenda, I do just want to review with the board, and I will bring this up again at the larger board meeting, just some of the wins that we have had at JPS during these last 2 years, but more importantly over this last year, as we have gone through surges with COVID and as we went through an ice storm. And I just think that it speaks to how the JPS team continues to not make excuses as to why we cannot get through surveys, why certifications, and continue to improve the care and work that we do for our community and for our patients. So there's a lot here, but I just want you to look at in making Washington Monthly named as the best hospital in the United States. And Ms. Debose did call this out at our celebration of light. And the staff truly appreciated this recognition. Just in 21, I'm not going to go through all of these, but again, named Outstanding Health System for DFW in the Dallas CEO magazine. We had 5 JPS nurses that made the DFW Great 100 Nurses. We probably could have named every nurse that came in and worked that bedside, but we did have 5 that were named in March. We maintained some of our certification with our stroke, chest pain. We opened up our behavioral health recovery center, and that's been a huge success, and I know the staff has enjoyed that. The behavioral health staff has enjoyed having that space. We went through a really good CAP survey. Really, we did well with our survey, and that is the lab survey. We went through our cancer center reaccreditation and had a great reaccreditation visit. And you can see here, and again, I will bring some of these up. Most importantly is our leapfrog, that we had a B in the spring and an A in the fall. And then probably where our heaviest lift was during these very challenging times was in our maintaining our preparation for Joint Commission, and we had a very good survey. Very good survey. So.
And you're going to elaborate on that a little bit at the board?
At the board meeting, I will, Dr. Weber. But I just wanted you to know that is what the staff has been doing, and I know many of you do know that. So, with that said, Dorothy, do you want to move on?
Yes, let's move to
Okay.
the.
And I'll ask Lauren Poe to join me up here. We'll go through where we ended the year with our AIP and LTIP, and I'll go through that. And then Lauren will present the proposed goals for FY22. And those will look a little different than our 21 because we now have a strategic plan that those goals are pulled from. I don't know if we can we kind of have a better shot of these because I don't see. See if we can. They're going to try to center that for us. And these are goals that the board approved last year.
There you go.
Yeah, can't quite get it on.
We should be able to see it up here.
I could probably talk, no, I've got a copy. It's up on there. Thank you. I can probably talk through this if they can just put up the slide. Our first one is our quality metric, and that is our PSI 90 that Dr. Stevenson brought before the quality committee a number of times. We do know that last year was a challenging year with the number of COVID patients we had, the acuity, not only of our COVID patients, but also patients who were now seeking care for the first time after pretty much of a lockdown in their lives for 1 year. Just to remind the board that this goal, what we're looking at is reducing the number of potentially preventable hospital harm events. An organization such as ours, we set at 1 would be where we expected. You can see that we ended the year at 1.27. The second goal here is our service goals. HCAHPS, and is our first service goal here, that HCAHPS measures our inpatient patient experience. And our goal here was to really improve that patient experience across the 9 HCAHPS dimensions. The number here indicates the number of dimensions that we were able to score top box percentage, and as you can see, we ended the year at 2. Our outpatient, the teams did real well despite our volumes going down. Again, this is improving patient experience in the outpatient settings, which include primary care, our specialty areas, and our women's center. This is across 15 questions that are being asked, and the percentage of those questions that we score top box. And again, top box is above the 75th percentile. You can see that we ended at 69.3%, which placed us at stretch. The next one is our employee engagement, and we will be coming back before the board. We just received these scores, so I do not have the detail behind them. We had participation for our employee engagement and our provider engagement was a little bit lower this year than it has been in past years. We had employee engagement at around 70%. We have been closer to 90% in the past. I believe it was around 80% last year. And our provider engagement this year was a little bit above 40%. So there is some opportunity there. We ended the survey for employee engagement at 4.11 and provider engagement at 3.93. The red indicates those goals that we did not meet threshold. The green is where we have met stretch. And our final one was depression remission. And there was a lot of work that was done this past year. And this is probably the most important goal as we looked at just what's happening to all of us as we went through COVID and came into isolation. And so really being able to identify and screen early on, and then to be able to manage those individuals who scored high on the depression screening tool, and to intervene and to have great outcomes a year following that diagnosis or that screening that was elevated. This team has done amazing work. I believe we brought in additional patient navigators. There was a lot of resource that we placed around it, and it really paid off. You can see that our goal, we started at 8% and ended above 25%, and this continues to go up. So, and again, here we were measuring the percentage of JPS connection patients who achieved significant improvement with their depression within 12 months of their initial screening.
So I've got a question. So we've got quality service, people, population health, and I see how that works into the equation. And then we've got the 6 metrics. But are those the only 6 metrics that we measured this year? Or how did we pick these 6 to put on this screen?
This is the AIP, the annual incentive plan. So there are a lot of metrics across the organization that we follow. These were the ones that that the board approved last year that would be used as part of the annual incentive plan and award.
Okay, so we went specifically to these metrics.
Yeah, they was
Yes.
presented
Okay,
to
that's what I
us.
don't remember. I
Yeah.
remember the weights and everything else,
Yeah.
but I don't remember the specifics.
They presented them to us, we reviewed them. It was a difficult meeting because there was a lot of questions asked, and then we finally approved it. And they came back on one for us with additional information. But each year, we go through these, and then we approve them, and that's what they work toward the next year. But yes, there are other stuff being done, a lot of stuff being done. And part of that is for us to figure out how we can bring some of that to the board. Okay.
All right, thank you.
And when do we make that selection for the next year?
They're going to present them to us today.
Today.
And we'll discuss them, and then you will have time to review them. We don't have to approve them today, but you need to get information on them today, because at our next meeting, we should be approving them.
At this level or at the board level?
We can do it here, but we also take it to the board.
Okay, cool, thank you.
Any other questions?
All right.
We'll move on to just where we resulted out with our LTIP. Quality was our leapfrog, and as we know, we did do really well with leapfrog this year, having scored an A. And then our stewardship goal for LTIP was the modified cost per adjusted patient admission. And again, some of the challenges that we had with COVID, with our volumes decreasing and the acuity of patients that were presenting to JPS, we ended the year at $16,527.
Any questions on that?
And then,
Wait a
remember-
minute, Roger looks like he has a,
It jumped so fast, I was just looking at the goals and the performance results.
okay. Okay.
And then, remember, we do have some physician executives that actually practice, and so the stewardship one has changed to a people, which is physician alignment. They started at 3.74. This result was from the survey, showing that they ended at 3.78.
Any questions? Sam, you okay? Do you have a question? Okay, all right. Everybody's so quiet, I'm kind of worried.
What were we measuring with physician engagement?
So engagement across the organization is really looking at how an individual, whether it's a physician or employee, how they perceive their place within the organization. Are they proud to work here? Would they recommend it to family members? Do they have what they need in order to be able to do their work? When we look at alignment, especially around the physician, is how well do they align with both the strategy that the hospital has and with that executive team? So it really speaks to that relationship. Okay, if we can move up to the FY22 proposed goal. I am going to ask Lauren Poe. I believe many of you know Lauren Poe because she led the retreat for the strategic plan. She will, moving forward, present out to the board an update as how well we are doing with our strategic plan, which will include a full scorecard. Roger, I know you asked about, are we following more than just that? The staff has put together a full scorecard based upon that strategic plan. There are a lot of metrics that are on that will be presented out on an ongoing basis to the board. The goals that you will see today as the proposed goals for 22 are goals that were pulled off of that scorecard that we felt would allow work across the network to continue and also address some of our JPS connection management. Lauren will be presenting that on an ongoing basis to the board, so I've asked her to come and present it here. It will look a little different than our previous AIP or LTIP. LTIP will look the same, but AIP will look a little different because it'll align with our strategic plan. So, Lauren, first of all, I just want to thank you for all the work that you have done with all of the staff and the executive team in order to put these goals together and to have conversation around it. And I think they are good goals. We had opportunity to present these to Ms. Debose and had good discussion with her. And I think she would agree that these are good ones that we could really see some improved outcomes for our patients.
Thank you, Dr. Duncan, and thank you, Board, for allowing me the opportunity really just to speak on behalf of the larger group in the background. So I'm just one voice today, but I represent a lot of voices as we walk through this. As Dr. Duncan mentioned, you can see on this screen that this looks very different than the slides you just looked at, right? So the pillars are not there. Instead, we have 3 different buckets. And again, the reason for that, as Dr. Duncan mentioned, is when we started down the strategic planning process a year ago, we heard from you, board members actually, in your interviews and your planning sessions, that you wanted us to move away from that pillar model and move towards alignment towards the newly developed and approved strategic plan by you all. And so over the last 6 to 9 months, staff, executive team have been working very hard in the background, like Dr. Duncan mentioned, to put together an entire organizational goal scorecard that does align with the strategic plan infrastructure and includes both strategic metrics that track KPIs towards the goals that you outlined for us to work on, but then also incorporates operational, financial, quality, safety, all the things that go on in a health system. And so to that point, I will be coming back before you after the first of the year to show that full scorecard, and you will see updates on that scorecard on an ongoing basis moving forward. The goals that we will present to you today that we will walk through, again, as Dr. Duncan mentioned, are a subset of those overall organizational goals. You see here again that it's broken up into 3 big buckets this year. Those 3 big buckets, again, align with the infrastructure of the strategic plan. So if you recall, the strategic plan had our true north, which is, we think, the most important part of the entire strategic plan and why we're here every day, and that's our patients. There's the kind of middle section, which is the strategy section of the strategic plan that speaks to all of the strategic initiatives and things that you outlined for us staff to work on to get us to where it is that you want us to head as a network. And then the last section are those strategic enablers. And as a reminder, these are those things that are critical to not only the network being successful on a day-to-day basis, but also the plan itself being successful and being able to be achieved. And so that is where you see those operational, financial type of measures and people measures would flow into, is that enabler section. So with that, again, as Dr. Duncan mentioned, we worked very hard with the team, executive team and staff to put these together. I will say we are very confident that these are good measures. While we can't say that they are COVID-proof, we do feel strongly that they are still the most important measures that need to be tracked and represent the most important work that needs to continue to be done in FY22, regardless of whether COVID is here or it isn't here. So with that said, we will go ahead and move into the first measure. So again, first measure represents the most important reason we're here every day, and that's our patients. And so again, consistent in years past, we will be tracking patient experience. Kind of the movement this year is that we are moving towards an overall patient experience across the network, meaning that we have incorporated all 6 of the service areas into this measure this year, rather than just the 2 we've historically tracked. And so it will be looking at all the surveys across the network. Another kind of key change this year is that we have moved to a new survey vendor, which has allowed us for the very first time the opportunity to be able to benchmark ourselves against like hospitals in the country that are similar to JPS. So again, this is a consistent measure with years past for patient experience. Any questions on that?
Who's the new vendor? Isn't it Press Ganey?
Press Ganey.
Press Ganey.
We were on NRC, and we moved from NRC to Press Ganey.
Is this the survey immediately after discharge, or how does that work? Do you know?
Yes, it is completed after discharge.
So we won't get penalized when they receive the bill and all that stuff, and because usually, timing is very, very sensitive in these kind of survey.
Yes, they actually happen pretty quickly, to my knowledge, after discharge, and some of them actually happen. I know in the behavioral health setting, it's a little bit different. They actually happen on the way out the door as well in the behavioral health setting, specifically on the inpatient side, but it is after discharge.
Right. But let me ask you another question here, is that if we do it too early, as they just got discharged, how would we know, administrative staff continue to provide the communication and the type of care that we can tie the loop around, right? Because you can pick up the phone and yell and scream at them for payment. how do we measure? Is it done professionally, or is it done we use a third-party vendor that may use a different terms and words that
Who do we use?
could be
here?
insulting to patients that we don't know about?
So Prescaney actually does the survey. We do not survey our patients ourselves,
Okay.
but it is a standard survey and survey questions that they use for all of their hospitals that they service.
Because how I operate is, it's not what you give, but how you give it. So just want to make sure that we don't.
I'm not sure I understand your question, DT.
Well, I think we can encompass, while they're here, right? We can care for them.
Yeah.
But then the moment they discharge, and then the bills come in, or the question not being answered, or all that stuff leading to get into the system, we would lose that side of it
Oh, okay.
if we don't try to complete the loop.
I guess the question is, what is the time frame from the time that you're discharged to when you are getting your survey and information?
Right. Because the noise that I've heard, and I may not have the full picture here, but once they're in the system, the care is excellent. They love it. But it's just to get here or get into the system and all that stuff, if that's still patient engagement and all that stuff,
That is
we
correct.
don't
Okay.
have any measurement, or we don't have to zoom in on this one, but we don't want to lose sight that we're not looking at it from that perspective.
Yes, I'm not sure.
I think the noise has always been, I can't get anybody, I can't get into the system, I can't get qualified.
So there are questions that are directed
Right, but
just,
once they're in, it's perfect.
You're
But
right.
When they're not in, that's the problem that we have.
Okay.
right.
So I'm not sure.
There are some,
It's getting into the system. Are we asking those questions?
Right,
and
but
there
we're
are some
monitoring them.
questions included, DT, that look at that
Access,
ease of
how easy it
access
is for access.
to get
We
an
have it.
appointment and to get in when they need to be seen, and
So we
there
do
are
have that
questions,
in
yes.
We
place.
have that
Right.
information,
Okay.
yes. Now, this one will look at overall, how they see their overall visit at each of the areas. That was to give it more apples-to-apples comparison, but behind that survey will be those individual questions that allow us to look at where within that visit there is opportunity for improvement. And that will be shared with each of the service areas. And we'll be glad to bring that
Yes.
back.
So, let me ask a question about the numbers on this, because when we take the average of these 6 total service areas, is that an average based on the absolute number of surveys that were returned, or is that an average based on whether or not the correct number of surveys were returned relative to the scoring? Because if we ended up with 30% response, does that mean we still have a valid average to calculate into the overall score? Or does a 30% response constitute an invalid N, if you will? So help me understand
Sure.
what validates the overall response relative to the scores.
Sure. So we did use, to your point, it was a statistically significant weighted average. And the way that they did that weighted average is they did look at the actual response rate relative to how many, to your point, Trent, surveys would have gone out. And so we know, and you can see on those numbers, for instance, the outpatient area was weighted much heavier because it has the larger overall send-out and should have the larger overall return rate. And then our smaller areas are actually our behavioral health settings, and they actually received a smaller weighting in that overall average.
So then, Lauren, are we punished on the score if we don't receive the statistically valid number of responses in each one of these 6 areas?
We're not punished based off of the calculation, but it does help to account for for lack of a better term, an apples to apples, a fair weighting, knowing that, again, community health has the largest return rate, so they have the largest opportunity. Then, they have more area to cover.
Yeah.
It should be weighted higher, so we don't necessarily get penalized, but it does allow us to be fair across the service areas, so that those smaller areas have ability to make improvements, but that are relative to them, as opposed to being just an equal percentage across all 6 service areas.
So if you put these metrics in columns, then I understand how we can come up with an apples to apples comparison based on these averages on these 6 areas. part of me, though, says, are we also looking at our response rates? And are we making certain that we're maximizing our response opportunities within each of the first column, if you will, to make sure that if we don't have, because if we end up with a 30% response on inpatient and a 90% response on outpatient, I've got a problem.
Agreed.
Because now I've not really calculated the true inpatient survey because I didn't get enough of them back to see whether or not I'm getting a valid response. You see what I'm saying?
Yes, yes.
That's part of where I have a little difficulty, because we're trying to consolidate a gigantic amount of data into a very finite small box. And that's a little worrisome, because as Roger and I were sidebarring here, over the last 15 years, we've probably had 12 or 13 different mechanisms for measuring how JPS is doing. That's problematic, because we really don't have the ability to go back 5 years and see how we did, because we're measuring it totally differently now. And so that's one concern I have with this, is if we're going to make this movement, and I agree with the strategy, I really do. I think the strategy's good, and I don't have a problem with the new mechanism, but I think we have to be able to continue to maintain some tie to the historic quality levels that we've all sort of become accustomed to. And so I think, especially as it relates to this discussion on the AIP, I still want to be able to look at a leapfrog, for example, and look at the metrics that are in leapfrog. And leapfrog's not perfect. I used to fight about leapfrog back in my Baylor days. Still don't think it's great, but it's better than most. And clearly we've made some headway into leapfrog. Are we over consolidating this and risking some of the quantitative data because of what I just explained, rather than, or maybe in addition to, potentially relying on additional historical data that we do know we can compare, that we can go back and trace, leapfrog maybe being one of them? Is there a place in the measurement to be able to incorporate some of those historic standards that are recognized throughout the industry that don't put us in the position of having to go reinterpret the data every year? That's a long question.
No, it's a very valid one. So leapfrog will not go away. It is still an LTIP measure, and we'll get to that after the AIP. So it was an LTIP measure before, it remains an LTIP measure. So leapfrog will not go away. We will continue to track that. It will continue to be part of the LTIP incentive plan, so that will remain. That will not go away. But to your point on the other, I hear you loud and clear, and you make a very valid point. And I think that it will be important on the back end from when we start to operationalize the efforts around, this measure specifically, that there are those, to your point, quality standards held, looking at return rates, et cetera, so that all of that is still there and still present, and we fully intend for that to be, but that what we're reporting out here in this setting is, again, a cross-network a metric. And my hope that would be that when we come back after the first of the year with the full organizational goal scorecard, you'll be able to see where some of those other historic measures have landed on that scorecard, because they have not gone away. We still have PSI 90 on that scorecard. We've actually looped in, some additional quality. I mean, that scorecard has all of those things that you're used to seeing that we will continue to track, because they are important for the organization and our patients.
Okay.
But Lauren, HCAP has been with us all the time, so
Yeah.
we have information.
Yes.
And we've looked at it, top box, then we looked at different numbers on it. We've tried everything to get that one up. But we still maintain that data that shows where we were with that top box since we started. So that part is there. Outpatient surgery is one that I'm not for sure if we've looked at that, how long. It hasn't been one that I have.
So we have all 6 of these. year prior, so FY '21, we have been tracking them below the line,
Okay.
with the anticipation of coming before you eventually with a overall, network, at the response of you guys' ask in
Okay.
last year, that you wanted to see more of a network
Okay.
wide. So those have been tracked below the line for a full year, and I believe Laura brings those before the quality board as well, as kind of some of her supplemental information, but we have tracked those at least for a year for those 4 below the line.
Great, great.
So-
That will include the emergency department, because I know we've
Yes.
always followed
We've done
something
those.
on it,
And
yeah.
So we'll be able to bring that detail to the board as we present this goal moving forward, so that you see exactly how we
This
trended.
should, even though we're rolling it up, we still will be able to see where we are having a major
Absolutely.
Yes.
improvement or a major deficiency, and that should allow us to drill down to that, okay?
Absolutely.
Okay.
Okay.
Any other questions on that one?
We will move to the second proposed measure. So the second proposed measure falls, these next 2 measures actually fall in that second bucket, if you will, on our new scorecard, which is around again, the strategy work for the organization and making movement on the initiatives and the goals that you guys wanted us to start focusing on over the next couple of years. So this measure is looking at reducing the readmission, 30-day readmissions, for patients with a primary diagnosis of congestive heart failure. As we begin to start our population management work, and specifically focusing on that JPS connection population as part of this, we quickly identified or tried to identify where was the largest opportunity for us to start with, and that landed on, again, the congestive heart failure readmissions. We saw that the top readmissions for this patient population were due to those patients with a primary diagnosis of congestive heart failure. Thank you, Roger. I appreciate that. I apologize. So baseline for this measure is where our current performance stands, and then the target for this measure is actually based off of the national average for this measure as well. So we are able to benchmark ourselves against hospitals across the country and what they're seeing as their readmission rates.
How did we come up with heart failure readmission with 30 days?
Yes.
Not something else?
Yep, great question. So again, we were looking at data of this population, and I know, again, coming back before the board after the new year, we'll be coming with a full presentation for you guys of how we are utilizing data within these strategic work groups to drive the work. And so there's a whole presentation planned for you guys on that. But we've been looking at several data points and trying to, again, identify where there's opportunity. And the data showed opportunity here because it was the largest portion of readmissions for this patient population were attributed to heart failure. We also see our largest portion of overall admissions for this population attributed to heart failure as well.
Okay. So,
I'm sorry, Doctor. Yes, yes.
okay, so how do you weight all the other things into the annual incentive plan? What if next year you bring me this and this one's red, but everything else is green? How does that weight into, I guess that's where I'm disconnected from all of this. I mean, I understand why we picked this one and it's got it's gonna have the biggest impact. But if we don't meet the baseline, it doesn't meet at all. How do you weight everything else that might be in the green, so to speak?
You're talking about other measures
Yeah,
that we
other
may be
measures,
having around our
Yeah.
JPS connection
Right.
management? Well, I mean, I would argue that it's probably a good metric that we set, and that there still needs to be some work and would be carried on into the next year,
Okay.
especially like we did with our PSI 90.
Figure out why we didn't, rather than, to your point, I mean, how we,
Now, if we do really well with it, then we can look at, as Lauren has said, there are other, metrics that we can look at that impact both the care, the finances, based on length of stay, other things that drive a lot of that cost per member of our JPS connection as we manage that. If we do really well with this, then we would look at the next one that we see would have the highest impact in both in outcomes and
Okay.
care.
I think, Roger, on quality, if we improve, then, yeah, you're gonna monitor it, but then there's gonna be another one identified that's costing a larger admission. And so we would want to do that one so that we can make sure that we improve that care. Quality is one of those that, as you improve, you continue to monitor, but it's going to be another one that's going to pop out there that we should. But overall, you're going to end up with several of them because you got about 4 top diagnoses that we need to address to help improve the health status. So it's one of those that I expect to change.
Is this a CMS?
Yes, you were reading my
Yes.
mind. This is a CMS
CMS,
measure
yes.
and definition that we
Yes.
use.
Yeah.
I understand that part. What I'm not sure I do understand, though, is how this particular metric, along with supplier diversity spend, comes up to 30% on the overall. Is that subjective? In other words, where does the 30% come from relative to True North 35 and Strategic Enablers 35?
So we can talk through that, and that, to your point, we did kind of gloss over that, getting to the definitions. So each year, we do, Dorothy, as you know, we come forward, and part of this discussion is setting those percentages and weightings for each one of, historically, the pillars, now these, 3 called-out sections of the scorecard, and ultimately the individual metrics. In discussing this with the executive team, again, this was not an in-silo discussion. We talked to the executive team, got their thoughts, kind of heard, what their feelings were. In being consistent with the budget that you all reviewed and approved back in July, and with what we as a team have seen to be the biggest lift in areas of focus and the largest priorities next year for our work, that is how we kind of landed on these percentages. And so, as you guys recall, we talked about how the 2 biggest priorities this next year in FY22 are ultimately our patients and our people. Without our people, our staff and our physicians, we can't provide the care for our patients. And we know it's a rebuilding year after COVID. And so that is why we attributed the 2 largest percentages to those 2 areas. So you see the patients and the people equal 35%, with the goal of that actually carrying the largest weight of the AIP this next year at 70%, because again, without those 2 things, there's not much else that we can do. And then that left 30% for more of the strategy work for this next year. And we felt that while they are both equally important, we did feel that the supplier diversity spend was something, especially with the bond work and all the efforts that we're trying to do there around diversity, we felt that constituted a heavier weighting than what the heart failure readmission rate did this year. But again, I think that can be open for discussion. But that is how we landed on those proposed percentages for this next year.
Okay. I guess my tendency would be to maybe offer up that heart failure readmission is closer to a patient experience overall rating bundle relative to your 6 than I would putting it in this category of strategic imperative.
Sure.
I'm having a hard time understanding why, because that is a qualitative measure.
Sure.
I mean, all readmission is a qualitative measure. I'm not sure how that fits in strategic imperatives.
So, and I can just quickly walk through that. So the work outlined in that bucket specifically talked about the care model work and the management of that connection population as part of that care model work, and ultimately building those care models, coupled with starting to drive evidence-based clinical care across the network. And so we have teams in the background that are assembled with clinician and executive champions that are driving this work. The group that is working on that population management work and that care model work is the one driving this work. And so this was just one component, right? So talking about the strategy of how we start to manage that population and how did we pick heart failure, we know this is only one piece, but we can't boil the ocean either. We've got to figure out a place to start to make improvements there. And to your point, Dorothy, then we move on to the next one, because there's multiple opportunities in that population management space. So that's why it actually fits under this imperative work, is because that work is being driven by that care model goal that you guys set forth in the strategic plan, and this is just one element of that. This is the first measure, and as Dorothy mentioned, I think year over year, we will come forward with additional. We're tracking other measures in the background as well, but that's why it fits there.
Doesn't this one get measured twice then? I mean, doesn't this get measured also as a function of HCAHPS in terms of overall readmission?
Not HCAPS.
Not
HCAPS is strictly patient experience.
I'm sorry, the qualitative one of the six. What's the one of the six that has the, that has more of the
Admission
quality
rates.
indicators on it?
Are we talking about the readmission rate?
So maybe it's not there at all.
HCAPS is strictly the results from the survey that the
Yeah, I
patients receive.
misspoke, Lauren, I'm sorry. I'm having a hard time pulling this one out by itself relative to the overall patient base. I get the idea of us targeting the things we're doing worst at. I see that, I understand that. I'm having a little difficulty figuring out how the heart readmission issue rises to the top of strategic imperatives as opposed to being included in this overall bundle that's in your first set of measures. Because if I'm trying to pull out the pure quality elements from all of these, then it seems like there's a little bit in each one. And maybe this all shakes out fine once we see the full dashboard and the full list and all the indicators. But right now, I'm a little uncomfortable that we've picked out these that are the worst. I get that. But measuring the entire hospital system and all of the employees, the AIP, based on those, seems like really shooting a BB gun in the ocean. And I don't know that I'm comfortable that that's going to be a fair measure for us to measure this entire health network, especially as it relates to employee pay, because it's just such a small, minute part of it. I mean, if I took the number of readmissions from heart issues at this hospital and compared that to the overall patient experience, which is probably well over 1.4 million, 1.5 million now in terms of encounters at JPS, probably not even 1%. And so I have a difficult time putting that much emphasis on that one indicator, acknowledging that it's bad and we need to improve it. And under the assumption that improving that makes everything better, I can hear that a little bit. But I'm just a little dissonant over the notion that the entire AIP is going to be based on something that is such a small portion of our population. I'm sure you'll be able to talk me into it at some point in time.
Well,
But I'm just,
well, let me just say this. One of the focus that we talked about in that plan is we were going to now really know what we were doing with JPS connection. That's the care model that we are going to be studying. That is the group that we are charged to take care of. So we will know more. You're setting up a whole system to learn about what we are doing for JPS connection, the cost of that, how many of those are coming into our ER. That is one of the major focus that we will be looking at in the coming year on JPS connection, which we've never had in the past. And part of that is saying, how are we taking care of those patients? Our biggest strategy was developing care models that could go all over the system to make sure that we were delivering the best care, evidence-based, and wherever they go in the outpatient, inpatient, that is the measurement that you're going to be looking at. That's one of the deals that strategically we talked about. What I think I hear you saying is that the heart failure is 10%, and we've got the patient experience. So really, you've probably got about 45% of your stuff based on patients, getting information from patients, looking at patient care. Is that part of it?
kind of.
Okay.
I mean, not on the labor, but this is a big deal.
Yeah, it
This
is.
is a real big deal.
It is.
Because when we're looking at the system, the network over the next decade, one of the things that we've said we must do is begin diversifying revenue streams. Diversifying revenue streams doesn't mean we exclusively focus on connection patients.
Nope,
It
we
means that
don't.
we have to look at the entire patient base and do everything we can to make sure quality indicators are effective at the non-connection point, just as it is the connection point.
Correct.
So I just have a little difficulty
Okay.
getting that
That part.
focused, and especially when we're putting the entire employee pay plan
Yeah.
based on it. I just have a problem.
All right.
So Trent, maybe I can answer it. I think you offered a little bit more clarity in your question. We see that the work that we do will be applied to all patients that come in. We will not have a workflow that is for JPS connection only. We are pulling that out as part of this metric, but the work we do is across the full patient population that we serve. And so anyone that comes in for readmission, CMS looks at it, all patients that come in for readmission. We are just pulling this out as part of the JPS connection so that we begin to focus on the management of that JPS connection population. Again, whatever we do will benefit all patients that come into our door. We will not look at anyone differently than based upon.
Karen, won't we be able to look at what we're doing with that patient population and use it as we negotiate with other insurance companies saying, look what a great job we're doing?
Mm-hmm.
That will help us improve our reimbursement rate from
It's
insurance
management of
companies.
a population
Yeah.
that you can use later on to negotiate rates with managed care contracts. But again, I see the work that we do across the organization to benefit every patient that comes to JPS.
And to that point, the overall organizational goal scorecard looks at the all-payer rate, Trent, not just the JPS connection. So we're tracking both rates so that the team that's doing that work across the network does not lose sight of the overall.
And that's crucial, and I think everybody agrees that's the right thing to do. The argument I have is picking these relative to AIP. That's my problem. I in no way would assume that we're giving different levels of care for non-connection patients at all. My point there was the overall patient population is going to have to change demographically if we're going to be able to pay for our bonds and take care of all the stuff we have to operationally over the next decade. So that's an emphasis. It's a strategic emphasis, in my opinion. But to the extent that we are going to link this metric in this percentage to the overall pay plan, I just don't think that's 100% fair. And that's okay. I'm
And
one vote.
I have the same concern when it comes to supplier diversity, because how many of the 7,000 employees have anything to do with how much money this board appropriates and to whom? And that seems like a big step when you're talking about an annual incentive for all the employees, when a very small department really can sway that, and ultimately that should be a metric that this board is judged upon and not the 7,000 employees.
Okay. I'm just going to have to jump out here and say this.
Okay.
We've been playing around with diversity spend for years. We have never, ever put a lot of emphasis on it, and the folks that are making a lot of those decisions are the directors that select what they can buy. If you look at it, that's where the decisions are made, who they select, who they want to use, who they want to use.
Yeah, remember-
So, to me, I'm also going to say that I'm glad to see that, because we have so much focus on our bond program, which I don't want to lose sight of that either.
Yeah,
That's going to be major for us.
I'm not doubting the importance of the measure and having it judged. I'm just, when you look at overall 7,000 employees, if that's one item that doesn't hit, you know, you've got a nurse or a housekeeper or whomever, their pay is being affected by something that is so far over their pay grade that it seems a little unfair.
Okay, I hear you.
There's no doubt that
Yeah.
it's an important strategic imperative, and I'm glad it's in the strategic plan, because
Yeah, okay.
7% is abysmal. But as far as giving people extra compensation, it seems a little unfair. That's,
Okay.
I think what we're struggling with, Dorothy, is that as a board, we're responsible for the overall operation of this entity, and yet we're focusing on one piece of it. Typically, what I would think we would be doing is we'd be giving a whole number for the entire, and then a subset of that would be those that are particularly poor actors in the whole thing as a supplement to that, but still look at the whole picture, not just one aspect of it.
Okay.
I just have a quick question here. When you look at 7% spend and you're looking at all the exceptions that carve out, my biggest challenge is that do we understand enough about what's the total addressable market for our spend and what's the serviceable?
I'm not going.
No.
They hear their presentation on the minority expense piece of it, they're asking questions about it.
Is it? Okay.
Well, we're still dealing with heart failure.
As long as we're good on this one, then I have no problem moving on, but I just think, and to Zim's point, we, the board, basically have to answer the entire county for healthcare.
Right.
JPS. And no indictment at all on the data and the work that's gone into putting this together. But understand, as we measure JPS, and we talk to people on the street about JPS, these are not the metrics people on the street are going to talk to us about JPS. So I think there has to be some way to be able to go back
Okay.
and look at our traditional dashboard numbers, and I'm hearing that we can, so that's a good thing. The issue is it appropriate to hold all of the employees' pay tied to what I consider to be some pretty narrow metrics? And I'm not against
hear
it,
you.
Dorothy.
I hear
I'm
you.
just saying, you're hearing some of the concerns. I think you're going to hear some of the same ones at the board level.
And I hear you, and that's the reason we're having this discussion. And I don't have a problem with going back and relooking at it and seeing what we can come up with. Just
So-
give us some ideas of what it is that, because I do think it's critical that we do look at something.
I agree.
And I think that if the heart failure one is one that I'm pretty comfortable with because it covers so many patients. And that is something, whether we decide you want to see it here, everybody has got to work on that. Whether we put it on here or not, they are coming in every day. We are seeing them. And how we do that is concerning.
You bet.
And so that would make care better throughout the system. Everybody, every staff is involved in that. The people that's helping them make an appointment, when they come in through the ER, when we service them on the floor. So I see the staff all involved with that. And that's a system-wide approach that we know we have to address. If we don't have it here, we still have to address it. And that's just one piece that we are saying we're going to look at. And then next year, you're going to have another one. You'll pretty much so have 4 or 5 of those in the future. I don't want, I just can't have, I don't think that we ought to have a whole bunch of them now. And so that's why they were trying to pick out one. But I do hear you. And so we can go back and talk to the staff and see what they can come up
So
with.
we struggle with this every year. If you look at PSI 90, it does not include across the network. We did intentionally look at where there was work, what metric the work was spread more widely across the network. And to Dorothy's point, this readmission, there is a lot from the time the patient enters our system to the time they leave it. There is a number of individuals at every step, from the PAR who registers to the person who calls to follow up on that discharge call. So there are quite a number of individuals across the network. My philosophy around AIP is, where do we want to put the resources and where do we want to put the optics? And often, when the board has come forward and asked us to look closely at things as they pertain to JPS, and unless they are out in front and that we can resource them appropriately, it becomes difficult to really get those off the ground and to get them moving. And so what I heard from the board is that we need to begin managing that JPS connection. And there has been a lot of conversation around the diversity, equity, and inclusion. Sure. And so this was our conversation that we had internally as to how we can bring that forward, both to have the conversation with the staff on an ongoing basis what that would look like. Diversity, equity, and inclusion not only includes supplier diversity spend, but it would also include how do we begin to match our hires at the time that we are bringing individuals in? How do we ensure that we have a diverse slate of candidates that come in? And then how do we make that selection? So there's a number of opportunities and metrics that are being set. And so I do see that as Lauren starts to present that full scorecard, that strategic scorecard, that you will start to see a lot of this within that is more specific than these measures are. So that's my philosophy. I will be honest with you, and did not get a lot of buy-in from the staff that I said, let's go with patient experience and engagement. And those would be the only two. So I'd let you speak, Trent, because that was music to my ears. I did not get a lot of buy-in. I pretty much got attacked on many levels from the staff. And it was a reason that why we weighted the strategic imperatives a little bit lower. I do see that the majority of our work next year will be in just how do we engage our employees in this new time. And then most importantly, all the work that we can do if our patient experience, if we aren't meeting our patient expectation, it doesn't matter what we do on 30-day admission or supplier diversity. So that's my thought philosophy and how we had that discussion.
It's a good philosophy, Karen. I mean, it's a very good philosophy. I think as we grapple with those ever-changing metrics, because as we continue to try to target the things we're not doing as well as we should be doing, implicit within that is sort of a need to be very malleable in looking at our dashboard elements. I just want to make sure that that background of dashboard elements is always there, that we're always looking at it, and that we weigh it against these. And if we see an anomaly that begins to arise, that we carefully look at that, especially relative to AIP. Because all of my comments today, all of my comments have not been about whether or not these are valid measures.
No.
They have been about whether or not they are valid measures tied to AIP.
Yes.
So I think they're all great. I really do. But it's just going to be a challenge just to stay up with them. If we don't keep that basic dashboard of quality and, and all these elements in our headlights, we might make a mistake. So.
Very, very true.
Totally agree.
The PSQ 90, I mean, I'm a psychiatrist, for Christ's sake. I mean, can I influence any of those kinds of things? Not. So what's good about True North is that now we have 6 courses that give me a GPA. And so we can go back and look at each course and get, what did you get in PSQ 90? But that comes to my GPA for the year is that score right there on True North. So now I have skin in the game.
Yeah.
I can't play in all of those areas, but I can play in a number of them, which makes me now a partner with the AIP. Make sense?
Yes.
So that helps.
Great input, Alan. I
Right.
appreciate that, because to me, that helps the engagement component as well.
Yeah.
The more people we can get to skin in, the better. So I think it's great.
Okay.
Well, and the True North is big and then goes smaller, and it seems like the strategic imperatives was big and then went microscopic. Like if you just said strategic imperatives, diversity, equity, and inclusion, with 2 or 3 scores for that,
Yeah.
then I get it.
And we do have that, and I'm hoping that when we present that overall scorecard, to Dr. Duncan's point, you can see that these are a subset. Because the other element too to AIP, that when we look across the nation at other hospitals that have AIP programs, you don't want to get too many measures, because then it actually defeats the purpose of an AIP program. And so when you look at other hospitals, it's usually 4 or 5, not many more than 5, because then at that point, then the weightings become irrelevant, and is it really driving work? And so that is the hard part, though, to your point, Roger, but that was our goal, hopefully, with this new organizational goal scorecard that encompasses again, operations finance. It actually, you'll be proud, Trent, it has revenue diversification on there as a measure. It has
He said, why didn't you bring that? We could have gotten through this with just that.
Yeah,
But,
we have financial stewardship. We have the foundation, to Amanda. You know, I mean, we have measures on there that hit every single thing we heard from you guys that you said we have to start tracking. But the hard part is then taking that and condensing it down into an AIP program.
Yeah.
One note, I will say, you know, on the readmission, I think, you know, people you don't think would be involved, but there's going to be a lot of work around IT to this, because as we build out these evidence-based care models, and we're starting, again, we can't start with 30 diagnoses. We just can't. We got to start somewhere. And that's why we're starting, to your point, microscopically, because what we do with this diagnosis, we will then apply diabetes, you know, COPD, but there will be IT involved. They're going to have to start to build out workflows and BPAs and Epic so that physicians can quickly and easily follow the standard of care that's evidence-based. So to that point, not to belabor, but there's a lot of people and employees involved across the network on that.
And
work.
we had already started some work around congestive heart failure, so we weren't starting from ground zero. We had already started to build some of those components and felt that we were giving the teams an opportunity to be successful with this. Roger, I actually liked the way that you kind of looked at that. Could we call this more JPS connection management and then call out to that metric and then speak about diversity, equity, inclusion, you know, kind of as the big topic, and then call out supplier diversity? I like that, and does align with what we talk about overall patient experience and overall employee engagement. And I think that would make it a little bit easier to look at.
Yeah, Dr. Potowitz's analogy of a GPA.
Yeah.
Really makes it, to me, clear.
Maybe
because-
much more clear
Because
how
then, you know, when you come to supplier diversity, equity, and inclusion, that touches way more people than supplier diversity spend.
Yeah.
I think
It appears to me that on the strategic initiative is where all the discussion is so far. So is that something you want to bring back to us, stated a little bit differently?
Can we move through with maybe supplier diversity?
through the
and
measures
then,
at least.
Right.
And then maybe give us some indication as to
Because
how-
the spend is bump, but you do have other inclusion. Maybe that should be a little bit more. Kind of like you have under your strategic enablers, you have more than one thing.
And so
That
and
makes
the
sense?
The
I don't-
scorecard has a goal column, to your point, Roger. That's actually how the scorecard is set up. So we have the strategic imperatives, and under that, you'll see, to your point, it actually says diversity, equity, inclusion. But there's multiple measures under, and it just happens to be one of them. But there's multiple measures underneath that one. Same with, you know, patient experience or our patients. And then you look at finance, right? So finance has 3 goals. Those goals, like I mentioned, are revenue diversification, stewardship, and foundation. But then the metrics are separate from that, right? They're metrics that roll up to that goal. So that might be helpful to see how that.
Okay.
And we'll bring that scorecard
Can we bring that
back. I think had we presented that, and we had tried to get that in previous meetings and was not
Okay,
able to
Chuck
squeeze
has
it
been
in.
trying to get a question. I'm sorry.
Question. Is 30-day readmission part of the key performance indicators for a claim?
Key performance indicators
For a
for.
claim?
KPI for a claim, is it not?
We track it, we are looking at it, and so we have migrated to continue, to Mr. Petty's comment, actually last time, we're continuing to both make sure we crosswalk well and we align with the overarching goals of the network.
Okay.
So on that part, you'll just come back with us some additional information, because I had a suggestion, thought, well, we would just take True North and strategic enablers and we'd move on. But I'm willing to leave it in there.
My suggestion is I want to hear the whole presentation.
Okay.
And get a picture of it, because I'm not a no vote.
I know.
I'm not.
I know.
And I need their input.
Okay.
All of their input.
All right.
Make sure that as long as there is the foundation behind all of this, as long as we can always go back and track it down and
Yeah.
point it to the things that we've all come to know over the years, I'm gonna be fine with it.
Okay.
Because I trust their judgment a lot
Right.
more than I trust my own on this. So I'm not suggesting we change it. I'm just trying to get educated to the
Okay.
point that we can
All
defend it.
right.
So Derek, I don't know what I did to the clicker, but it's not working, so if you don't mind advancing the slides to supplier diversity spend. Next one. Next one.
Which?
One more, Derek? Thank
There
you.
it is.
So supplier diversity spend, again, to Dorothy's point, this measure is not new to you as a board. This is a measure that has been tracked, I know, in the background for several years, and that you have received periodic updates on at the HR committee. One of the things to make note of is the definition did change slightly to mirror the updated industry standard definition to match the MWVBE, which stands for Minority, Women, and Veteran-Owned Business Enterprises. And we did that also in order to be consistent with the bond goal definition that we have around the bond supplier diversity as well. And so that is just one thing to note. The other thing to note is we did reach out to peer hospitals, and so we did get information on Cook County in Chicago and Grady, as well as Parkland. And so our spend goals are in line and consistent with what we see with those like hospital institutions. Any questions about that? To Dorothy's point, I think, again, going back to stretching across the network, this is something that, like Dorothy said, a lot of those decisions are made at that director level. And so we actually have had a lot of background conversations around the fact that there's a lot of work to be done with this process, contracting process, just start to finish. And there's a lot of work to be done to identify opportunities where we can do better, make sure we're aligning what our documents say with what we're trying to achieve from a spend perspective. And it's going to take a lot of individuals to do that, not just executives, not just contracting department, but it will be, again, to Dorothy's point, leaders, et cetera. There are no questions on that one. We'll go ahead and move on and round out. Oh,
BT has a question.
I actually have a question on denominator. For that, I'm still struggling with what is the total addressable market and the service addressable opportunity for the minority
so
looking at.
So that
Because we
didn't-
carve out quite a bit when you take out the GPO and all that stuff.
So the denominator, a couple of things. We are looking at both Tier 1 and Tier 2 spend, so it's not just Tier 1. The second piece of that is the definition, so denominator and numerator both, are actually set to industry standards. So this is exactly how Parkland, that is one of the confirmation things we talked to Parkland about, is to understand what their exclusions were and their inclusions. And so this definition is, again, consistent with industry standard. The key piece of this is leveraging, companies such as B2G Now, et cetera, who have that database and platform that allows the opportunity for every time you go out for a service or a contract, they have the master repository that they receive from those national accrediting bodies for these minority-owned businesses, et cetera, that we're able to tap into and say, for this service or contract that we're going out for, is there diversity spend available to look at? And so they are kind of the source of truth for that. They also will help us do a better job of identifying those areas in which we have not tapped into historically. So where are those companies or small businesses, minority-owned businesses out there in different pockets of services that we historically have not done a good job of realizing that there is diverse opportunity out there for those services. And so that is a key component that other organizations like ourselves utilize, because that then helps them to determine, truly to your point, DT, what needs to be in that denominator. Is there diverse spend actually available in that service or not?
Is there a way you can help me understand what's Tier 1 and Tier 2? I don't think I see the definition.
Yes, so Tier 1 is contracting directly with an organization that is a MWVB certified business. Tier 2 is more of that subcontractor role. So they are they're subcontracting for a component of that work or for supplies that they're using to then sell to us. So we still count spend for that subcontractor Tier 2 work in that overall calculation, just like other organizations.
Here's the thing that I'm struggling with a little bit when you're looking at diversity spend, is I have a hard time connecting, is it landscaping, is it mostly construction, or is there other opportunity that we haven't identified or has been wrapped up by GPO and all that stuff? Because I would hate to see, the next 5-10 years turn around and say, that population only good with construction, outside labor and all that stuff, but all the intelligence and the thing that put them to school to better themselves are not available for them.
Yeah,
That's
so
why I'm
we know
hard
that,
time connecting.
traditionally, there are areas in which there's still some opportunities for some of this diversity. If you look at IT areas, for example, you don't see much in that area. I think what this does is to allow us to understand what is there. We have, as Lauren said, reached out to other like organizations. They've got good database that we will be sharing and using to not move forward with just saying because it's an IT contract, we could not, work with them to subcontract, that there is opportunity out there, and our expectation is that you will, connect with these minority vendors and bring that to us. We do understand that right now, construction, painting, landscaping, that we have more opportunity. I think it'll be important for us to carve that out and bring that forward to the board as to, how we're trending both in those very high-skilled areas and then some of what's been traditionally that we've done well with along diversity spend.
All right, thank you.
Is this process consistent with, and I presume part and parcel to the overall bond
It is.
process? And have we incorporated the expertise of our bond consultants?
We have. They have looked at
They
this.
weighed in on
Yes,
this, actually.
they actually weighed in on this, and so we did purposely align it with the work that Case Strategies is helping us with. You made it clear that best practices that Case Strategies has out there, you would like to see us incorporate this, and this is part of that.
Great, thank you very much.
Okay, we will move on then to the two engagement questions. These are similar to the employee and clinician engagement questions that you have seen on AIP in years past. Just one thing to note, we did go through an RFP process that you as board members ultimately approved, but we did switch vendors. We historically had used Press Ganey for our engagement surveys. This year we moved to a new vendor by the name of Gallup. And so that is just one thing to note on this, but the actual measures themselves still measure, again, the same measures that we're used to having on the AIP scorecard, which are employee engagement as well as our clinician engagement. And then Gallup did help us set our actual threshold target and stretch numbers.
Is there pros and cons for doing that, by splitting it out? Because sometimes when you have everything in one place.
Are you talking about clinician and employee? They actually are not.
Can I speak? I'm sorry. Lauren gets what she really is quick. So we looked at that. Could we combine that score together? And Dr. Becker and myself thought that, I personally thought much like you, could we combine that and look at it together? And after conversation with Gallup, and internally, we felt that at this point that we needed to keep it separate, that there was a little bit of logistics that made it a little bit more difficult.
Okay. Is there an opportunity for them to output so that we can bind data later on if we need to?
I'm sorry?
Is there an opportunity for us to output those data later on so that our decision support team can bind the data where appropriate to start looking at the how one can affect the other type thing?
I think that
we
would
may
be.
not have a use for it yet,
Yeah,
but down the road
no.
we may get to that point where we We need to
I do
combine the
think at
data.
some point we do, to your point, have to be able to look at kind of how do they interact with each other and drive each other's engagement. You know, I think that
That's
that's
a great idea.
something that we can get with Gallup about and understand kind of what their history and experience has been with this.
Thank you.
You're using Gallup now. What was the reasons to go away from Press Ganey to Gallup?
We knew this question would come up. Dr. Duncan prepared me well. The contract, of course, you know, we have a certain year contract with our vendors. So the contract was actually up for renewal. And we went out, the team went out for an RFP and had several respondents. Press Ganey was one of them. But actually, after seeing all the respondents and actually hearing pros and cons of each, Gallup actually rose to the top. They have some differentiators from the standpoint of having a larger database of hospitals and things across the nation for us to be able to benchmark against, provide some additional support. So they won the RFP process, even though Press Ganey did respond as well. So they actually came out the top vendor.
Also, we looked at our strategic plan and what we were going to measure. Gallup had Gallup actually had more questions as it pertained to diversity, equity, and inclusion. There were just some much better questions that would give us opportunity to really get behind the scene and be able to create some action plans around the responses.
Yeah, the reason I asked that, because I had another question, but you answered it. My question is, Gallup had served other like institutions. That's where I was going with that. Yeah.
Okay, if there are no questions, I will say, so that is the end of the AIP scorecard. We quickly do just want to remind you of what's on the LTIP scorecard as well, because that will be up for approval as well for the FY22 measures. The biggest thing around LTIP to note is the measures do not change. They stay consistent. And so the measures that Dr. Duncan walked through at the beginning of the meeting showing where we ended the year are the same measures that are being proposed for FY22. All that changes is how we set the threshold, target, and stretch. That's essentially what gets changed every year. So again, as a reminder, on the executive portion, oh, Derek, I'm sorry, can you go ahead and switch? Oh, my clicker's working now. On the executive plan, again, each plan, executive and then practicing physician executives, they have 2 measures each. The executive plan includes Leapfrog hospital safety score, as well as the modified cost per adjusted admission. And you can see on there again, baseline, which is where we ended the year, and then our threshold, target, and stretch for FY22. Any questions on that before I move to the practicing physician?
I have a question on cost efficiency, because we all know all the cost is going up tremendously, very, very high. So how can we fairly measure this without taking into consideration inflation, CPI, and all that stuff, like just a flat number that we pull out and plug it in? I mean, labor force is expensive too. If you can't find them, you get contractor in here. That's another 30-40% jump right there at least. So I'm for it, but I'm not just trying to be fair to the employee if we're gonna.
Yeah, this is
that way.
the executives actually that this LTIP is around, and we, Dorothy will let you know, we struggle a little bit with keeping this one. We felt it was important not to Trent's point, keep changing out and not have something to continue showing improvement around. So as a result, we did keep this one with, and you're exactly right, these costs are continuing to escalate and we've seen that. Yes.
Then not keeping up with reality. But, you know, it's important there, but I just want to make sure we adjust it correctly. But not use that to play the game.
Exactly. As you know, it's been one that we've struggled with, so there's still a lot of opportunity.
Any suggestion from any other board member, how we need one, what? Yes, uh-huh.
Some sort of a multiple, whatever CPI
Mhm. Right, just, you know,
That's punitive without it.
So Sharon, do you want to maybe speak to it? Because I do think that she does take that into account.
So, when we look at setting this, we do base this on the budget. But what it's really sensitive to, at least from this year, is a CMI change. So as these patients have gotten very acute in '21, that's driven a very unfavorable outcome for that metric, as well as the decreased volume that we've seen throughout the year in both inpatient and outpatient. So there is some escalator that is built into here based on the approved budget, but CMI and volume are the real sensitivities here.
Okay, any other questions to?
Quickly, just as a reminder that on the practicing physician LTIP plan, we removed the stewardship measure and we replaced that with another people measure, and that people measure is historically the clinician alignment, and it is now the equivalent of clinician alignment with the new Gallup survey. So that will be the replacement here. But again, same measures that we've always measured, just with updated baseline threshold targets and stretches.
Okay. Any other questions on the presentation? And I want to be sure what they're, so if they're going to bring, what they need to bring back to us.
Good work. That was a lot of work. That's great. No criticism at all. Just, we have to evolve with this.
Right.
We've got to understand it. We've got to keep it flexible as long as we can drag us along. Keep the lesson is what we know and understand. Educating us in the process. All good.
Can make a recommendation that I would ask that the board approve the proposed goals. We can make some small amendments in calling out those bigger categories that Roger suggested, so that it does seem to be more network-wide as opposed to very specific that you spoke about, Trent. But it would ask that for an approval from the board for the proposed FY22 goals.
I'd move approval.
All right.
I'll second.
All right. It's been moved by Trent, second by Roger. Is there any other discussion? All those in favor signify by saying aye. Okay. All those opposed by nay. Good job. And I really want to appreciate y'all having the information about what you based it on, your methodology. That was wonderful. And so nice to see.
Well,
And Zim did not have to tell me to get in the weeds this time, to get out of the weeds. So I'm really proud of that. Thank you.
And thank you to the team in the background, because we've had a lot of partnership this year with data analytics, et cetera. So thank you to them as well.
Dorothy,
Yes.
I just want to say that the presentation, even though Trent had a lot of questions.
He did. He drilled us, didn't he? We started at about 5 o'clock this morning preparing, and I gave Lauren, like, this is what Reverend Emerson's going to ask, this is what Trent's going to ask, although Trent always surprises me.
But I just wanted to echo what Dorothy said. The presentation was really clear. I was able to understand better today than really our paid consultants who have sat down there and made the presentation.
Okay. All right. That will conclude our open session, and we will, do y'all need a break before I go into closed session? Okay. Huh? Well, I'm hoping it won't be as long as open, but it might be, but I think it will be short. And here's what I'm asking, is committee members and the one that are doing presentations to stay for the closed session. You know, we got new lady in town, and she's saying, here's what you gotta do, so.
Well, Trent asked how long the closed session's gonna be?
Okay. Well, I don't think it'll be that long. Okay, I'm sorry. We were reconvened in open session at 12 minutes after 12. And we still have one item that we need to complete, so, concerning the annual and the LTIP, so.
I'd like to make a motion that we approve the annual and the LTIP as presented. With the caveat that the full-time employee contribution to within our margin. Does that work? That works. Dorothy? Daphne? Is that close?
Definitely, is that close?
That works.
That work? Okay. All right, can I get a second?
Second.
Okay, Ralph, second. All right, it's been motion and second. Are there any other discussions? There being none, all those in favor signify by saying aye. Aye. And those opposed by nay. Okay, motion carries unanimously. There being no further business, we will adjourn. Thank you.